Good morning everybody. Today we will be learning about the next part of the hormones, that is estrogens and antiestrogens. So the first part of the menstrual cycle and the early birth phase, most of the females will be under the influence of this estrogen. I think you already know how estrogen influences the female reproductive system, how it helps in generation of the main reproductive organs. Today we will be learning some drugs which can affect their metabolism and the therapeutic usage of this estrogens and anti-estrogens. So starting with natural estrogens, that is estradiol. It is the most potent and it is secreted by the ovaries. Okay, so that means it can also be secreted by other organs also, but primarily it is the ovaries. Estrone formed by extragranular conversion of androstenedione in peripheral tissues. Okay, so estriol is a conjugated metabolite of estrone and estradiol. Here comes the biosynthesis and metabolism. Okay, in biosynthesis and metabolism, first the primary molecule here is cholesterol. From cholesterol we have pregnenolone, then testosterone, then estradiol, estrone and estriol. Okay, so this estriol is present more commonly in the postmenopausal women. Okay, so the preparations are available for the estrogens. Okay, so the preparations are estradiol benzoate, sapienate, valrate, which are given by IM injections, estrone and estriol, and synthetic ones they can be given orally. Ethinyl estradiol oral, they are used as a part of this oral contraceptive pills. Mestranol, it is a prodrug, finasterol and tibolone, which finds its use in the DUPs. So synthetic preparations, we have non-steroidal estrogens, diethylstilbestrol, which can be given orally, okay, and dinestrol, chlorotransinase and methyl lanistril. These are the synthetic compounds. So where this estrogen receptors are present, we should know estrogen is not only acting on the primary organs of female genital tract, it can act also on some other parts of the body. You can see here in the brain we have this estrogen receptor alpha and beta, both receptors are present. In the breast again we have both the receptors alpha and beta. In the liver we have only alpha receptors. Okay, so where the metabolism of the metabolism or conversion to estrogen takes place. Cardiovascular system, both alpha and beta receptors are present. So if estrogen is decreased, the female can go for depression. In the breast there will be lack of fullness and they can go for atrophy. In the cardiovascular system it is told that as long as the female menstruates, she has lesser risk of getting heart attacks, not up till 40 years approximately. Okay, and how this is possible? This is possible by increasing the good cholesterol, that is HDL, and decreasing the bad cholesterol, that is LDL. Then coming to the gastrointestinal tract, where we have the estrogen receptor beta, where there is increased glucose absorption. Okay, then urogenital tract, so this is the main tract where the estrogen actions are seen. Both alpha and beta receptors are present. Okay, in uterus alpha receptor is dominant and prostate beta receptors are dominant. And in bone we have seen that what happens in postmenopausal women, there is osteoporosis. Okay, so there, if the estrogen receptors are acting well, there is proper bone formation. So knowing these ideas, we can think of some of the conditions where a single drug can act as a agonist antagonist like action. So this is mainly because of the receptors on which it is acting. Okay, so we might have seen some of the partial agonist, okay, partial agonist and competitive antagonist are there. Do you remember some drug which is partial agonist also, and when the agonist is not present it can act as a competitive agonist. Okay, there are some drugs here, so we should be careful in understanding the concept because of the different receptors distributed at the different places. Okay, with this idea we will move on further. Okay, you can see here the receptors which are present there, briefly described in the previous slide. So what are the beneficial effects of this estrogen target tissues? For example, this we can consider it as a normal estrogen secretion and also the therapeutic hormone replacement therapy. Okay, what results we can expect here? So in the breast we can program the milk production. In the liver and the heart, that we told now, it increases HDL, decreases LDL, controls the cholesterol. In uterus it prepares the for the fetus, uterus is prepared for the fetus. Then increase shear bone, it preserves the strength, that is it prevents the osteoporotic condition. So what can be the harmful effects? Natural estrogen, can it cause harmful effect in the body? Yes? Yes, it can produce. When it can produce? Only when estrogenic action is there. Progesteronic action is not there so much. How can it be possible? If the female doesn't undergo the pregnancy at a proper age, okay, maybe like within 30 years or so, she is not becoming pregnant, she is not bearing. In such conditions what can happen? There can be more estrogenic action on most of the glands, you can see here. So in a nuns, okay, that is in the church we find there the chances of this breast cancer and uterine cancers increase. You can see here we have marked the veins, so there is more chances of deep vein thrombosis also if the drug is acting. For example, if estrogenic drug is acting for a longer period of time. So in estrogen replacement therapy in menopause, what are the good effects? Strengthening of the bone, lowers the LDL, raises the HDL, reduces the menopausal symptoms, that is hot flushes. These hot flushes we can also see in the premenstrual syndromes where the estrogenic action is more, the female is having pain and tenderness both in the uterus and the breast. Okay, this is mainly due to the increased estrogenic action, and this can be relieved by progesterone drugs, or a natural progesterone can also take over. So bad effect is increased risk of breast cancer, blood clot, increased risk of uterine cancers. So how this estrogen acts? Where the receptors are present? These are mainly the cytoplasmic receptors. Okay, so estrogen molecule, once it comes and attached to the receptor, this slide I have put because to identify where our drugs are acting actually. Okay, so for understanding where the drugs are acting, this slide is helpful. So estrogen molecule, we have a cytoplasmic receptor, then it can be transferred to the nucleus. Okay, then there is activation of the co-activators where the DNA molecule acts and there are response elements. These response elements are in the form of messenger RNA and the specific proteins. Okay, so thereby there is change in the cell behavior. So this transformation and formation of this specific proteins, formation of messenger RNA, all these processes take some time. Okay, so there are some of the effects which are immediately carried out and lesser physiological importance. Okay, that means there are some other pathways where immediate reaction is also possible with the estrogen action. Okay, but the major action which are physiologically significant are in the form of this pathway. So estrogens, starting with the drugs, that is diethylstilbestrol. Okay, so diethylstilbestrol, where we can give this, this can be given in prostatic cancers, inoperable prostatic cancer, and is absolutely contraindicated in women. So mode of action, we just learned it now. The similar mode of action that binds to the cytosolic estrogen receptors and complex being transported in the nucleus, where the androgenic activity is antagonized by receptor competition. So metabolism, we know that it is liver is having this estrogen receptors where it can go for metabolism, primary hepatic metabolism with conjugation and renal excretion. So it should be contraindicated in conditions where estrogenic dependent cancers are there and possibilities of cancer are there. Okay, contraindicated men with cancer of the breast, any estrogen dependent neoplasms, thromboembolic disorders. So what are the other therapeutic uses? So we already learned this, it is just a summarization, you already know this concept. Osteoporosis, we are using this conjugated equine is horse. Okay, so conjugated is equine estrogens or estradiol, it is used in osteoporosis. Vasomotor symptoms, okay, most probably in cases of menopause or premenstrual syndrome, short-term conjugated equine estrogen therapy is done. Cardiovascular disease, yes, it is not the primary mode of treatment, but partially it can be helpful. So estradiol estrogens, that is sodium estrone sulfate, and in case of urogenital atrophy, in case of where female is expecting late pregnancies, maybe 30-35 years, we need to give some estrogens to bring back from atrophy to normal epitheliums. So neuroprotective and CNS effect, insomnia, fatigue, in these cases we can use it. Okay, synthetic non-steroid derivative, estrogenic, progestrogenic, and weak androgenic effect. So because of this multiple mechanism, we have found their use here. So estrogen replacement therapy in primary ovarian failure, and estrogens in cyclical pattern, they are given to regularize the menstrual cycles. Okay, ethinyl estradiol, this is part of this oral contraceptive pills. So dysfunctional uterine bleeding, mainly the progestin find their use, but estrogens are also tried to regularize the cycles there. So dysmenorrhea, painful menstruation, mainly NSAIDs, and some cyclic estrogens are. Acne, hirsutism, these are hirsutism mainly occurs after the chronic use of this oral contraceptive pills, mainly because of the progestrogenic effect. Okay, pigmentation, hirsutism, main problems with the progesterone, where estrogen can take over and decrease that symptoms. So estrogen adverse effects in case of males, when it is used for this prostatic cancers, it can lead to gynecomastia, feminization, and it itself can lead to prostatic cancers, migraine, breast tenderness, amenorrhea. Okay, so if prolonged estrogen effect is there and there is no progesterone effect, it can lead to amenorrhea. So this concept is used in oral contraceptive pills. Okay, so it can lead to gallstones, hepatic dysfunction. Gallstones and cholestatic diseases are common with both estrogen and progesterones. So contraindicated in diabetes, where the blood glucose level can be increased, hepatic failure, and thromboembolic disorders. What are these anti-estrogens? So knowing the effect of estrogens, where it can be used, and what are the demerits of it, usually the common demerits are after the long-term usage, that is breast and endometrial cancers. So we have found the drugs where our anti-estrogens can be helpful in preventing such conditions. So blocks the estrogen receptor, breast cancer, and we need to use a drug where the positive effects of estrogen should be present, but they should not work on the negative effects. So such drugs are also available with us. We call them as selective estrogen receptor modulators or SERMs. Okay. So what are these? So selective estrogen receptor modulators. Okay. The concept that single receptor, single response may not be valid, because we have both alpha and beta receptors, and because of this receptor change and changing the mechanism of action, there can be beneficial effects only, avoiding the bad effects. Okay, that we will be learning it later. Here you can see tormorphine, normorphine, Raloxifene. These are the family drugs. Okay, so estrogenic for bone growth, antiestrogenic for uterine endometriosis. So we need to prevent the osteoporosis. At the same time, we do not want this endometrial cancers and all. So such tissue specific activities can be seen here. Okay, so just 2 slides before, we have seen that how estrogen is acting. This is the normal mechanism here. Here you can see how here, this is the normal mechanism and this is a SERM here. Okay, so for example, here the normal estrogen has come and bind to it. What will happen? These are the coactivators. You can see here, these are the coactivators. There is, once it has been transported to the nucleus, the coactivators have worked out, and there is DNA binding to it, and there is a tissue specific protein release which can be used in the red cell production or any other action. But once this has bind to this, actually this is you can consider it as a estrogen. Here you can consider it as a SERM. Okay, so SERM can bind there. Okay, estrogen receptors in the breast cell, breast receptor not activated, and breast cell concentration. So tamoxifen citrate, this is one of the SERM. Okay, selective estrogen receptor modifier. Indications is adjunctive treatment for breast cancers, prevention of breast cancers in genetically predisposed women and men. There are steroidal antiestrogens and non-steroidal antiestrogens. Here it is a non-steroidal. Mostly the synthetic ones are non-steroidal, and compete with the estradiol for the estrogen receptors in the target breast tissues. Okay, and the metabolism is by hepatic. It conjugates that are renally excreted. Okay, and hepatic failure is possible if it is used for a longer time. Thromboembolism and primary is pulmonary embolisms are common with this drugs. As with our estrogen, direct estrogen or the equine estrogen therapy, the thromboembolic phenomena are common in HRTs or hormone replacement therapies. So for this, one more thing is estrogen therapy can lead to this endometrial cancers also sometimes. So regular gynecological examination once in 3 months or once in 6 months is necessitated after this therapy. Though we tell that there are lesser side effects, these examinations are necessary. And along with this, if you are using some hormonal contraceptives, that can be problematic. So then if the patient is on these drugs, sounds better to go for a non-hormonal contraceptive methods. So how this tamoxifen is helpful? It increases the bone density, reduces the LDL, increases the HDL, and increased risk of cancer is there, that we already learned. Dose is 20 mg per oral 4 times. This is just a repetition. Okay, here you can see the estrogen molecule binding and activation of the co-receptors, co-activators. Here, once the tamoxifen is binding, what is happening? There is no relative change which should occur for the binding of this co-activators. This is not there, so there is no binding of the co-activators, and further action, downstream actions are not taking place. Here you can see tamoxifen receptor does not acquire the change shape which is necessary for the binding of this coactivators. So tolmepine citrate used in breast cancers. In breast cancers we have this estrogen receptor positive and estrogen receptor non-estrogen receptor cancers. Both are there, where the diagnosis is still not made that the breast cancer is dependent on the estrogen or non-dependent on the estrogen. Then also we can start with this tolmepine citrate. Mechanism of action is similar to all the SERMs. So extensively metabolized by cytochrome enzymes. Enterohepatic circulation is there, and as with other estrogenic drugs, thromboembolism and endometrial hyperplasia, and sometimes it can lead to metastatic bone lesions and suffer with hypercalcemia. So Raloxifene, one more drug in this group, SERM. Okay, so Raloxifene and Tamoxifen citrate, these can be short notes for you. Okay, so developed for again breast cancer, treatment and prevention of osteoporosis in the postmenopausal women. See here, one common feature with tamoxifen and raloxifene is they are both antagonist at breast. Antagonists act as antagonistic to estrogen at the breast and agonistic properties at bone. So both in breast cancer and osteoporosis they are helpful, but in uterine tumors or uterus related issues, so they differ in their action. Tamoxifen acts as a partial agonist, but raloxifene is an antagonist. So raloxifene is better in also endometrial cancers and all. So in addition to the benefits with the bone health, 90% reduction in the new breast cancers are also seen. Raloxifene is effective in breast cancer and also in chemoprevention. So coming in general, raloxifene is better than tamoxifen. You can see here, strengthen bones. This diagram, if you put in exams, it will be more helpful to fetch you good marks. Okay, that's why I put this diagram again and again. So strengthens the bone, lowers the LDL, reduces the risk of invasive breast cancer, shear uterine cancers. Then tamoxifen, you got to know why it is so. So fewer blood clots than tamoxifen. So bad effects, hot flashes are not that much, and lobular carcinoma in situ, ductal carcinoma in situ, these are not. These are types of breast cancers. Their effects, their cancer effects is not controlled sufficiently. So here is the summarization of the SERMs. Okay, so estrogen, it is stimulation effect on all the tissues. Tamoxifen, you can see on the uterus, endometrium, it stimulates. Okay, that is one bad effect. Raloxifene, it blocks both bone stimulates. That's what we need. Raloxifene, you can take raloxifene and genistein. It is a soya phytoestrogen. Okay, all last three are beneficial in both in breast and uterine condition. Tamoxifen may not be that much helpful in endometrial conditions. So you can see here, all of them can reduce the LDL cholesterol, and only estrogen, tamoxifen, they have beneficial in increasing the HDLs, genistein. So this is just a summarization of the estrogenic effects. You can see it helps in maintaining the body temperature, reverse the memory. Okay, and if it is not there, what can happen? It can be hot flushes, night sweats, mood swings. All these things are there. In the breast, you can see milk production, it is helpful. If it is not there, estrogenic effect is not there, the fullness of the breast is not there, and there is atrophy. So ovaries, it stimulates the start of the period, but once the action is lost, there is no more periods. In vagina, it is helping lubricating and healthy vaginal lining, so sexual activity is more comfortable. If there is dryness, there can be discomfort and bleeding. In the bones, it helps in increasing the bone density, so loss of body strength, that is also there. In uterus, it prepares the uterus for the developing baby, hardening liver increases the HDL levels. So coming after the estrogenic effects in the after the first part of the cycle, we have the effect of this progesterone. Okay, this progesterones, it is helping in maintenance of the pregnancy. It prevents the untimely failure, miscarriages, and all. So that's why in pregnancies we use this progesterone touches, progesterone gel capsules are used locally, and maintain injection, which is very popular. It is a progesterone injection which maintains this pregnancy. So it is like a, you can tell that it is like a policeman. Like once the ovum and one sperm has entered into the uterus, okay, what it does, it helps in nidation. Nidation is where it will go and settle and form the uterine conceptions. Okay, from the conceptions there should not be any disturbance from external side. For that it is helping. It is like a policeman which prevents the further entry of the sperms, further coming of the ova. It blocks both the ways. Okay, further ovulation is prevented, further sperm penetration is also prevented. How it does, we'll be studying it now. So normally you can see the normal pathway which we started with, like in estrogen synthesis. Okay, the primary molecule is cholesterol, then pregnenolone, 17-hydroxypregnenolone, okay, DHEA, dihydroepiandrosterone. Okay, you might have seen this in some other preparations. Okay, directly they act there. Then conversion to estrogen, androstenedione to this one, it is taking place with the help in the liver. Okay, so estriol, estrone, and estradiol. All these are synthesized. Here is progesterone. So progesterone derivatives we have medroxyprogesterone, mesogestrol acetate, dihydrogestrone. Newer is normogestrol. 19 non-testosterone derivatives we have norethindrone, levonorgestrol, lansiterol, okay, aldosterone, and newer compounds we have gonones, desogestrol, norgestimate, and gestodine. Try to familiarize with these terms. Okay. So progestins, 19 non-steroids, the progestins. Okay, after removal of the 19 carbon change, major hormonal effects from androgen to progestins, and they can be maintained with the oral activity. Normally all hormones, they don't have the oral activity. The synthetic one have this oral activity. So these esterates, they have some androgenic activity also and anti-estrogenic action. So gonones, what are these? Gonones are more potent than esterates and less androgenic activity, and now is a third generation oral contraceptive combinations. These are norgestrol, norgestimate, and desogestrol. So progestins, how do they act? The mechanism is they interact with the progestrogen receptors to mimic the stimulatory effect of this progesterone. So the action is to prepare the uterus for the nidation, prepare the uterus for the new baby to survive well there. So what it does, estrogen decreases estrogen-driven endometrial proliferation, that is prevented, establishment and maintenance of pregnancy, and it is usually inactive orally, but the 19 carbon derived synthetic ones are active orally. So TR is very short, 5 to 7 minutes, and they have a very high first pass metabolism. So, So think of a cycle. First part, there is endometrial proliferation and preparation of the uterus for the action of this sperm to enter it well. So the secretion should be watery, okay, so that it can help in movement of the sperm. Once it has come in, what should happen now? It should block the way. So blocking the way is more cellular secretion should be produced, more viscid secretion should be there, so the sperm cannot penetrate. And another effect is prevention of the ovulation. Okay, so all these effects are seen. I'll just put on the slide where you can see the surge of the estrogen hormone and the progesterone hormone.